Well, good evening, everyone, and thank you for tuning in on this snowy night. I hope everybody's warm. My name is Scott Blois, and I'm one of the cardiologists over at Boulder Hospital. And I just wanted to start a little bit by telling you who I am. I'm originally from Northern California, 54 years old. I did my undergraduate training in Los Angeles at UCLA. And then I went to medical school in Houston at Baylor College of Medicine, which was very famous and is famous for its cardiovascular care. Some of the early first heart surgeries were done by Dr. DeBakey there. I came up here for my first tour of duty in Colorado in the 90s and did training in the medical school when it was still in downtown Denver before it went to Fitzsimmons. And then I, in 2000, went to Austin, Texas, and I ran a heart failure transplant clinic there for about 15 years, but Colorado drew me back, and I was happy to come to Boulder in 2015 and start the first heart failure clinic here in Boulder County. I've been here about 6 years now, and it's been wonderful. Our heart failure clinic has grown. We see over 700 patients, and we really emphasize learning, teaching, dispelling some of the myths, but also co-managing with our patients and getting them on the best medicines. Because you'll hear in this talk, heart failure is really becoming more of a chronic disease than how severe and a death sentence it was 30 to 40 years ago. Let me get rid of this little box here. For the next 45 minutes, I'd like to follow this outline a little bit. I'd like to give you a definition of what I think heart failure might be. As you're going to understand, it's a term that we use for a lot of different things that can cause the heart to not work well. I'd like to sort of talk about the growing prevalence of heart failure and that it's really one of our most costly cardiovascular problems in America. Maybe to learn a little bit about the signs and symptoms of heart failure, learn some of the leading causes of heart failure, and then learn what are some of the tests we use to diagnose somebody with heart failure if we're suspicious about it. Briefly, we're going to talk about some of the principal treatments of heart failure, including the medications that have been developed, pacemakers, defibrillators, but is it just the important lifestyle changes you have to learn about and embrace to live with this chronic disease. We'll talk a little bit about what a CHF clinic is, and then leave some time for questions. So if you look in a general cardiology textbook, the definition of heart failure is when there's a clinical syndrome that ensues when the heart's really not able to pump enough blood to supply the metabolic needs of the body. And this is a schematic of what a heart looks like. You can see the top chambers are called the atrium, atrii, and the bottom chambers are called the ventricle. The left ventricle is really, when we talk about heart failure, the main muscle chamber of the heart. And disease processes that can injure the pumping chambers of the heart, in particular the left ventricle, cause heart failure. Unfortunately, heart failure is pretty common. Before the pandemic, we would give a lecture to 100 people in the audience. And unfortunately, the statistics would say about 20 of the people in the audience would develop heart failure. About 1 in 5 people will develop heart failure during their lifetime. There are about 5 million cases of symptomatic heart failure patients in America, and probably another 5 to 6 million people that are walking around with their heart not working well, but they don't have the symptoms yet. And one of the keys is to diagnose the problem and get on treatment as early as you can. That portends to a better response in treatment and results. Unfortunately, there's been a lot of improvements in congestive heart failure. One of the reasons I became interested in being a heart failure expert was from 90 on, the last 30 years, we've had a lot of advancements and improvements, but with that still, there's about 500,000 people a year who will develop heart failure, and unfortunately, even with our best treatments, about 250,000 people a year that die of heart failure. It's a very costly disease. In 1998, the United States spent about $20 billion on heart failure. In 2014, it had almost gone up to $32 billion. And the estimation is by 2030, it'll be up to $72 billion. It is the most costly heart problem in America. If you added all of the costs that we do to treat heart attacks and bypass surgeries and heart stents and combine them together, it's still not as much as we spend to treat heart failure in America. We'll talk about it, but it's very common, unfortunately, for a person to be admitted to the hospital with heart failure. They're prone to fluid building up in their lungs, and an average length of a hospitalization for decompensated heart failure is about 5 days, and right now is costing about $30 to $40 million. Excuse me, $30 to $40,000 per hospitalization. So the bad news is it's very costly. The good news is it has the attention of the government, Medicare, biomedical companies, pharmacology companies, and there's a lot of research going on in this process with a lot of improvements happening almost every year. And this just shows a little bit of a different form, a graph showing the prevalence of heart failure. And as you can see, the graph continues to go up as heart failure is becoming more common. So what are some of the symptoms of heart failure? I like to use the acronym FACES, and it stands for, the F is fatigue. Very common when the heart's not working well, fatigue can happen. Activities are limited. Congestion, the heart is not working as well, and some of the medicine or some of the hormones that we're going to talk about that are activated when you have heart failure make you retain salt in water, plus the heart's not working well and the lungs can fill up with water. So chest congestion. Also, water can build up in other places in the body besides the lungs, and you can get edema in your legs and swelling. And then lastly, shortness of breath is probably one of the most common symptoms along with fatigue for congestive heart failure. These symptoms, especially of shortness of breath and fatigue, are not solely what congestive heart failure. And so there are some diagnoses that are out there that are commonly, they're diagnosed with something else when really after a while it doesn't get better, becomes heart failure. And one of them is, for example, asthma. Asthma is much more common than heart failure, but if you've been diagnosed with asthma and they've put you on inhalers, they've put you on steroids, and you're still not getting better, one thing is to step back and say, could this be an atypical presentation of heart failure? Pneumonia, again, happens frequently, but I will see probably 10 people in clinic during a typical year that have been on multiple courses of antibiotics for infection in the lungs and not getting better. When they turn their attention to could this be the heart weakened and heart failure, we find out that really this was heart failure, not pneumonia. Same with an upper respiratory infection. And then lastly, depression and tiredness in an older patient. It is very common as you get older, but at the same time, that's some of the symptoms of congestive heart failure. And I guess, again, stressing that it's important to diagnose heart failure as early as we can. We know the more upstream you can start treatment, the better the results are and less deadly this disease will be. So what are the leading causes of heart failure in the United States? Number 1 and 2 are sort of interchangeable, but coronary artery disease, cholesterol blockages in your heart arteries that causes a heart attack and damage the heart, is probably one of the top 2, as is longstanding uncontrolled hypertension. So it's not getting your blood pressure one time at the supermarket being high, but it's really somebody who went to the dentist, went to the internist, their blood pressure was 180 over 100, and they said, you need to get on medicines or lifestyle changes to fix this, and doesn't. If you stay at that kind of blood pressure for months to years, this will cause the heart to fail. The third one is called an idiopathic double hit theory. And idiopathic is a fancy term for we're not exactly really sure. But the thought is you probably have a genetic predisposition to getting injured from a heart standpoint, and then a virus attacks your heart. And versus somebody else who maybe doesn't have the genetic predisposition to heart weakening, the virus just causes an upper respiratory infection, a sore throat. But in this type, a person who has some family history of early heart failure, the virus attacks the heart and weakens the heart. The fourth most common is the valves stop working. As you get older, the valves can either get stenotic or they can start to leak and have regurgitation, which makes the heart not work well. And then the fifth is alcohol. We know that if you're drinking probably more than 1.5 alcohol drinks per day, it turns into a toxin not only to your heart but to your liver. So alcohol, unfortunately, is sort of in the top 5 for causing heart to weaken. But this is a very busy slide, and what it's mostly meant to say is there are many, many different things that can cause the heart to weaken. There are toxins. We talked about alcohol. Chemotherapy. Some of the best medicines to treat breast cancer and some of the cancers of the bone marrow and lymphatic system are cardiotoxic, and we know that. You've got to take the chemotherapy to get over the initial cancer, but a lot of times there can be problems with heart weakening afterwards. There's things, for example, HIV medicines can be cardiotoxic. Some of things like carbon monoxide and lead can be. Here in Boulder, we do see cocaine cardiomyopathy. There's some metabolic things that can cause the heart to not work well. The thyroid, the adrenal gland are very much related to how the heart works, and if there's abnormalities of those endocrine glands, there can be heart failure. Electrolyte problems, potassium, magnesium, not just a little bit, but chronic electrolyte problems, very severe, can cause problems. On the other side of the table, you see some of the infectious things, not only viral, but bacterial, TB, and parasites. In South America, the leading cause of heart failure is actually a parasite called Chagas disease that injures the heart. So in third world countries, you have to think about infection, and unfortunately, COVID affects the heart about 20% of the time when you get a COVID infection. Non-infectious things, autoimmune processes, lupus, rheumatoid arthritis can cause the heart to not work well. Pregnancy, the body does incredible things when it's pregnant, but it can have cardiomyopathy caused by that, probably from a endocrine hormonal imbalance. And then lastly, some of the neuromuscular things, which are usually genetic. Duchenne's can be at myotonic dystrophy, and a lot of times it's pretty obvious there's other family members that have had musculoskeletal and heart problems before them. So if you have one of those symptoms of the acronym FACES, or you have one of those disease processes and you're thinking, I might have heart weakening and heart failure, what are some of the tests that a doctor, whether it's your internist, family practice doctor, general cardiologist, or the heart failure clinic, would order? Well, they'd start with something very simple and inexpensive like an EKG. One of the things that we can see on an EKG, the heart, when it's weakened, starts to get enlarged and thicken. It's not working as well, so it wants to fill up with more blood to try to pump it out. But that can come across on an EKG as some signs of hypertrophy of the heart. You can see signs on the EKG of a previous heart attack, maybe. And just like the heart muscle can be weakened, the electrical system can be weakened. So on an EKG, you're really looking at the electrical heartbeat, and you can see abnormal slowing. It's important to get labs. You have to check for anemia. You have to check the kidney function, the liver function, and the thyroid function. A chest x-ray, again, is very easy to do and inexpensive. On a chest x-ray, a lot of times we'll see the heart getting bigger. And as we talked about, people with heart weakening are prone to fluid building up in the lungs. So we might see infiltrates consistent with water building up in the lungs. So a chest x-ray is important. The last two I have separate slides we're going to talk about a little more in detail: echocardiogram and brain natriuretic peptide, which has nothing to do with the brain and all to do with the heart and is a blood test. So an echocardiogram, and this is what the machine looks like. You come in, you get into a gown, and our sonographer takes a probe about the size of my thumb, puts a little gel on it, puts it on your chest, and it's the same equipment that when a woman's pregnant, they do an ultrasound of the baby, or they do an ultrasound of the gallbladder. But we're doing an ultrasound of the heart to see how it's beating, and you can see in that still frame the left ventricle beating. It really is probably the most important test we do if you have concern that you have heart failure. It will really tell you the strength of the heart, tell you how the valves are doing, if the heart's gotten enlarged, hypertrophied. So I would challenge people, if you really think you have heart failure, to ask your doctor to get you an echocardiogram. It takes about 30 minutes to do. There's no needles involved, and a very important test. The other one, and this is used a lot in the emergency room to evaluate a person who has shortness of breath to make sure they're not having heart failure, but it's also used in my clinic and a lot of clinics, is called the brain natriuretic peptide. And it's a misnomer for brain because it's really a protein that's in the walls of your heart. And if the heart is weakened or dilated or congested, it releases this protein into the bloodstream. So the best is to have a low protein level in your bloodstream. The higher it is, the more suggestive of heart failure. And for example, it's very good, the specificity and sensitivity. When you come into the emergency room, if they draw this blood test, and it's usually back in about 20 to 30 minutes, but if it's above 400 or 500, that is about a 90 to 95% chance that the shortness of breath is coming from heart failure problems. On the flip side, if it's less than 100, the chance that your shortness of breath is coming from heart failure is about 2%. So it's a really helpful tool to evaluate shortness of breath and also to tell us if the heart's not working well. There are some other disease processes that can cause the BNP to be elevated. That's why it's not 100% accurate. Lung problems like COPD and pneumonia and a blood clot in the lungs can cause the BNP level to go up, but not as usually as high as somebody having a heart failure exacerbation. And then also, if you've got kidney weakening, your kidneys clear this protein so that it could rise with kidney problems. It also happens when you get older, usually above 85, and also if you have pulmonary hypertension. But still, an echo, BNP level are very important to evaluate for heart failure. If we're getting into sort of other tests, maybe slightly more invasive, we talked about one of the top two reasons why the heart weakens is cholesterol problems. So if you have an echo that shows your heart's not working well, your cardiologist or heart failure clinic is going to want to really make sure that it's not because of blocked arteries, because if you could get a stent or a bypass and fix the blood flow, the heart is going to get better. So one of the things we do is a lot of heart catheterizations or coronary angiograms, which basically is taking pictures of the main three arteries in the heart and making sure there's not cholesterol blockages. MRIs of the heart are done. They're very helpful, especially when we're worried about an autoimmune problem. There's certain patterns we can see on the MRI, or if they have infection or a cancer or tumor in there. A stress test sort of is the same as the heart cath. We're looking to see if there's any cholesterol blockages limiting blood flows. And labs, as we talked about. Interestingly, genetic testing is really only used in about 30 or 40% of people. It's going to get better, but it's not something we use in 100% of people. Why? We're still learning a lot about the genes that cause heart failure in families. And right now, unfortunately, private insurance and Medicare is not paying for it completely. So sometimes people who want it get stuck with a large bill themselves. But we do genetic testing in about 30 to 40% of the people. So I sort of said there's many different types of heart failure, but if you have heart failure, it's usually divided into two types of heart failure. And this is related to the medical treatments. One is called diastolic heart failure. And this is when you do an echo, the actual heart looks like it's beating well. It hasn't been injured by a heart attack or a virus or anything. But what we know is the heart is gotten stiff and not relaxing well. The heart likes some time to relax and fill up with blood and then pump it out. And diastolic heart failure is a problem with relaxation of the heart. The ejection fraction, or the strength of the heart, is actually normal. Systolic heart failure is when the heart, you can see on the echo, is not beating well. The main heart in a person who's never had any heart problems, usually on each heartbeat, pumps around 50 to 70% of the blood out. Nobody's heart pumps 100% of the blood out. If you're really pumping less than 40 or 45% on each heartbeat, for whatever reasons injured your heart, that's called systolic heart failure. There's sort of this mixed heart failure when your ejection fraction is 41 to 49. An ejection fraction, you can get, it's a number on the echo or on a heart cath or on a nuclear report or even on a cardiac MRI. So diastolic heart failure, we're going to just talk a little bit about. It's very common. Some of the common causes are longstanding high blood pressure, atrial fibrillation, infiltrating processes. One of the more common ones that's happening is called amyloidosis. Coronary artery disease can cause the heart to stiffen. And then unfortunately, natural aging. As you get older, your heart gets stiffer, and there can be just diastolic heart failure from aging. Unfortunately, there's no clear medicine when they've done many studies with beta blockers, ACE inhibitors. We're going to talk about those in systolic heart failure. But all those studies have shown sort of a neutral effect, but none of them showing great effects. So really the treatment in a diastolic heart failure patient is to treat the underlying problem that's causing the diastolic heart failure. If it's high blood pressure, getting really good blood pressure control. If it's related to atrial fibrillation, trying to get them back in a normal rhythm, or if the electrical system's so stubborn that you can't get them back in sinus rhythm, control the atrial fibrillation rate. Unfortunately, about 50% of heart failure in older populations, when you get above 70, are from this type of heart failure. There are several different classification systems for heart failure that I want to go over briefly. And this, it's important once you have diagnosed heart failure to get an idea of how severe it is. It'll help give you an idea of prognosis and some of the medicines to use. One of the oldest classifications for heart failure is called the New York Heart Association system. And a lot of times in my clinic notes, if you go on Portal and you look, I'll say they have class 1, class 2, class 3, or class 4. So it's part, when you're reading your note on the Portal, you could look at that. 1 is the best, 4 is the worst. So a class 1 New York Heart Association symptom heart failure patient is you have an objective test that shows the heart's not working well. Maybe the echo shows the heart's pumping at 30%. But when you really ask that person, are you at all symptomatic? Do you have shortness of breath? Do you have fatigue? The answer is no. They can hike up Mount Everest without getting any shortness of breath. Those people still should probably be on some treatment. Class 2 is there's mild symptoms. And for this, a lot of times I'll ask, if we started walking down the sidewalk, how many blocks could you walk? And if you start to get short of breath when you've walked 3 or 4 blocks or further, that's class 2. Class 3 is if it really, you can't make 2 blocks without getting short of breath, that's considered class 3, or going up 2 flights of stairs. Class 4 is you're short of breath at rest. You're sitting there on the phone talking to somebody getting short of breath. And that's the most significant concerning class of heart failure. The heart failure societies realized, again, the more you can start treatment and catch heart failure and heart weakening at an earlier stage, the better. So they said, you know, there are some diseases which are so high risk for going on to heart failure. We're going to call that class A. So that's high risk for heart failure, and that's people who have hypertension, who have coronary artery disease, who have diabetes. That's scary to think that if you have diabetes, you're already sort of being talked about for heart failure. And then if you have a family history of heart failure. And when we say family history, it's usually somebody who's developed heart failure in their 30s, 40s, or 50s, not 60s, 70s, or 80s. By then, unfortunately, as we talked about, 1 in 5 people could be getting this. Class B, this ABC system, is sort of like the Class 2 New York Heart Association heart failure symptoms. Class C is sort of like the Class 3, and Class D is the worst. Again, short of breath, symptomatic at rest. Why am I spending so much time going over this? Well, this is a chart that shows a little bit about, based on what class of heart failure you have, statistically, what's the chance of being hospitalized for heart failure and what's the chance of dying of heart failure, even despite our best medicines. So a Class A person who's really has diseases that maybe could be high risk but hasn't developed any heart weakening, you can see there's about a 2% chance of dying per year and about a 1 in 400 chance of being hospitalized with heart failure. That person who says, I can walk about 5 blocks before I get short of breath, that'd be a class B. They have about a 5 to 15% chance of dying per year and about a 1 in 200 chance of being hospitalized with heart failure. My clinic rooms are about 100 feet away from our lobby. That person who walks down the hallway to my clinic and is already short of breath is probably what we call a class 3. And you can sort of see there's about a 20% annual mortality rate with that, and there's a 1 to 2 hospitalization per year average. That's starting to get pretty serious. And unfortunately, that person who's short of breath at rest, the class D or stage 4, has a greater than 25% annual mortality and can be hospitalized 2 to 4 times a year. It's not to take away the hope of the patient or scare somebody away. It's really to say, this is a serious problem. We have treatments, but it's not something you can go away for 6 to 9 months and come back. We really need to start treatment soon. People ask, well, what is the risk factor with COVID? And COVID's been going on for about a year now. There is some concerns. We know that a person with chronic heart failure is at risk with a worse outcome if they get a COVID infection. We know in the general population, if you get a COVID infection, probably the chance of dying from it or getting very, very sick is less than 1%. Because the heart is weakened and your body just can't handle the stress of the infection, a person with heart failure has about a 10% chance of dying if they get COVID. This is where we sort of take a break and we all hug each other and say, that's the bad news, but I want to spend about 15, 20 minutes talking about the good news. And it's one of the reasons that I went into congestive heart failure treatment because there is a lot of improvement. Before 1990, if you developed heart failure, we could treat you with diuretics, Lasix, digoxin, which is a very old medicine, been around for over 100 years, and actually morphine. Morphine is a very good medicine for dilating the lymphatics in your lungs and getting rid of some of the fluid. But we didn't have any medicines that could stop the problem, and if you really type in heart failure, you might bring up studies and statistics about heart failure from pre-1990, which show that the survival is about as good as metastatic breast or lung cancer, and that really the 5-year survival rate was very poor unless you got a heart transplant. In the 1990s, researchers learned that when the heart's been injured, probably both in diastolic but definitely in systolic heart failure, your body reacts by turning on 3 or 4 hormones to sort of whip that heart to keep working hard, to whip that horse to keep running. And those hormones come from the heart, the kidneys, the adrenal glands, and some other organs. And those hormones are not good for the heart. They whip the heart and make it get weaker, and that's not good. So one of the things they found is if you can block this hormone, the heart can actually get better. And so this is a slide that sort of shows on the top one, myocardial stands for heart. So you have something that's hurt the heart. The heart then becomes dysfunctional or weakened, and it turns on all these hormones that you see in the middle block. And we're going to talk about some of these hormones, but the main hormones are actually your adrenal system. If you have heart failure and we take a vial of blood, your adrenaline level is about 8-fold higher than anybody else. Also, there's a hormone in your adrenal gland, which is this little almond-sized gland right next to your kidneys, and your kidneys called the renin-angiotensin system. And that hormone level is elevated, along with some other ones. And what they found is when these hormones are activated, they hurt the heart. And the real treatment for heart failure is to block those hormone surge. So what are some of the medicines we use for systolic heart failure? Not necessarily diastolic heart failure. We're going to talk about systolic heart failure, which is probably the worst of the two. And one of them is called beta blockers. Those block the adrenaline surge that can happen in a person with heart failure. They actually can slow the progression of the heart getting weaker and actually make the heart get stronger. People are surprised when I said, yeah, your heart can grow back. It might be pumping at 20%, and after you've been on these medicines, we do another echo in 6 to 12 months, and it's pumping at 50%. It's not like your spinal cord, when it's broken, you're paralyzed. The heart actually can regenerate. The medicines that are approved in the United States for heart failure on a beta blocker are Carvedilol, which is also called Coreg, and metoprolol, which is called Toprolol. In Europe, there's another one called Diastolic that's approved, not here. ACE inhibitors and angiotensin receptor blockers. The other main hormone that we talked about that's activated that comes from your adrenal glands and kidneys is called the angiotensin, renin-angiotensin system. And ACE inhibitors, angiotensin receptor blockers, and something called ARNI blockers are out there, and they block that. Lastly, there's a mild type of diuretic called aldosterone blockers, and the main one out there is spironolactone, which also, besides being a mild diuretic, blocks hormones. So one of the things when a heart person comes in and the echo shows it's pumping at 20% is we get you on multiple medicines to block this hormone surge and give that heart a chance to not be whipped and to sort of start to relax. And probably one of the most important slides is this one. This was done back in the 90s, and now they wouldn't do this study because it would be unethical. But they found when they studied ACE inhibitors in over 7,000 patients, at 1 year if you took an ACE inhibitor, you dropped your chance of dying by about 16%. And if you took beta blockers with 8,000 people studied, you dropped your chance of dying by 36%. So if you took those two pills, you are almost decreased your chance of dying by 50%. And so now, if you really have an echo that shows your heart's pumping under 40 to 45%, please challenge your doctor to why you're not on a beta blocker and on a medicine to block your renin-angiotensin system like an ACE inhibitor. And it's not only being on the medicine, but being on the right dose. They found that the more of the medicine you take, a lot of times the better chance the heart's going to get weak or stronger and that you're not going to be hospitalized. And this was a study when they found out that Carvedilol, one of the two beta blockers we talked about, was safe and effective in heart failure. They looked at people with taking placebo, 6 milligrams, 12 milligrams, and 25 milligrams, and as you can see, if you got up to the 25 milligram dose, it gave you the best chance of your heart getting stronger and the best chance of not being hospitalized. So it's not only being on the right medicine, but it's being on the right dose. And that's one of the things the heart failure clinic will do is we'll get you on the right medicine. Maybe your heart isn't strong enough to take the biggest dose right away, but we work up to that. There was some concerns last spring about using ACE inhibitors and angiotensin receptor blockers and the COVID infection going on. And that's because we found that the SARS-CoV-2 virus attaches when it attacks your body to the ACE2 receptor. And one of the things that ACE inhibitors and angiotensin receptor blockers do is uptitrate this receptor, make more of them appear on the cell. That's a good thing for heart failure. But they said, well, maybe if we're putting more of these receptors out, the body's going to be more prone to being infected by COVID. And what they found was that was not the case. After about a month, both the Chinese and the US cardiology, which were sort of giving the first one, said no, taking people off their ACE inhibitor and angiotensin receptor blocker right now is a bad thing. You die of heart failure much more fast than that small chance that you get COVID. So that was found to be not true, and they put a strong recommendation out not to stop those medicines. Other medicines we can use in heart failure are diuretics. We talked about your body's prone to fluid building up, so Lasix, furosemide, torsemide, Demix, hydrochlorothiazide are used. Those don't block the hormone surge, so they don't get the heart stronger, but they definitely keep you from being short of breath. Digoxin, which we talked about, which was one of the medicines we used a lot before 1990, we don't use that much anymore. There's a very narrow therapeutic range. And with that, unless you really have atrial fibrillation, in general, we're not using that a lot. And then there's a combination of isodural hydralazine, which has been found to be especially helpful in the African American population that has heart failure. People ask about supplements in heart failure, and unfortunately, the studies have not been that dramatically good. Omega-3 free fatty acids are helpful, especially if your heart failure is from cholesterol problems and you've had heart attacks. That helps prevent further heart attacks and dementia. Coenzyme Q10 is helpful if you're on a statin to lower your cholesterol. It helps mitigate some of the toxicities of the statin. And a multivitamin has been helpful. And if you're anemic, then iron is helpful. If you're not anemic, it hasn't been shown to be that beneficial. Unfortunately, the rest of them, from vitamin D to vitamin C to vitamin E, have all been very neutral at best to sometimes harmful. So the recommendation is, as we're going to talk about, when you are diagnosed with especially systolic heart failure, there's no one magic bullet. You're going to be on 4 to 7 medicines. And if you're taking a lot of supplements that maybe are not proven, there's a lot of chance for drug-drug interactions. This slide, the first paragraph, talks about a new medicine, and it's getting a lot of TV time right now, called Entresto. And it's basically a drug that is starting to replace ACE inhibitor and angiotensin receptor blockers. The short answer is it blocks that hormone surge coming from the adrenal gland and kidneys probably a little better than that. So we are starting to use a new class called an ARNI agent, Entresto, in lieu of ACE inhibitors and angiotensin receptor blockers sometimes. It is still brand, not generic and expensive, but a lot of times we can fill out the forms and get it down to maybe about $30 to $40 a month rather than $300. The rest of the medicines, luckily, have been around a while and are generic. Changing from medicines to pacemakers, we talked about that the heart is weakened, both the muscles weakened, but the electrical system is weakened. And with that, a lot of times it's gotten very slow and you need to have pacemakers. If on your EKG you have a long QRS, that means that the bottom chambers, pumping chambers of your heart, your left ventricle and your right ventricle, are not beating in sync. And a biventricular pacemaker will help that. And then lastly, we know that if your heart, even on the best of medicines, can't be pumping more than 35% of the blood out on each heartbeat, you're at risk of having dangerous arrhythmias that originate from the bottom of the heart, called ventricular arrhythmias. And so they've invented pacemakers that have a defibrillator in it, which basically gives you a shock if you go into those arrhythmias. So we do actually have, not, I would say still only 30, 40%, but we have a lot of people with pacemaker defibrillators. We're not going to spend a lot of time here in Boulder. We don't have a heart transplant or mechanical heart program. We have a very good one down at the medical school in Fitzsimmons. But there are about 5% of people with heart failure that we cannot keep the heart going with medicines and pacemakers. The nice thing is 95% of the time we can. The treatment of a ventricular assist device is something where they can actually do an open heart surgery and put a mechanical heart in, like this shows, which basically can take over the pumping function of the heart. And it's come a long way. The first ones were in the 1970s, and they were about as big as a refrigerator, and the bearings in them lasted about 8 days. Now they actually are big enough to put in my hand, and the bearings can last for 3 to 4 years. So there's some people that they put it in with the strategy that they're going to live with that for the rest of their life. Other ones, they put it in as a bridge stabilization until they can get a heart transplant. And this just, you can look at the handout we have on the internet, but the first organ transplant was in 1947. It was a kidney transplant done in Boston. Denver's famous for having the first liver transplant in 1963. But the first heart transplant was done in December of 1967 by Dr. Bernard in South Africa, and then quickly in January of 68 was done here in the United States by Dr. Shumway at Stanford. There are now over 2,000 people with heart transplants living. There's about an 85 to 90% survival at 1 year and about a 50% survival at 10 years. That's a whole separate lecture, but it is some of the more advanced heart failure surgeries we can do when our medicines and pacemakers don't work well. To finish up for the last sort of 5 or 6 minutes, I want to talk about some risk factor and lifestyle changes. You can be on all the right medicines and still not be feeling well if you're not doing the right things to help with the heart. And one of them, and we do a lot of this at the heart failure clinic for both the patient and their family, is do education. For example, a blood pressure for a person who has heart weakening is very different than a blood pressure for somebody who doesn't. A normal blood pressure for a heart failure patient is about the top number 95 to 120 and the bottom number 50 to 70. The heart is prone and the body prone to fluid building up, so we talk that you have to restrict how much salt and water you take in. Usually about 8 glasses of total fluid a day is as much as your body can absorb through the stomach, pass through the veins out to the heart, and then out to the kidneys to pee out. If you're drinking 5 or 6 glasses of iced tea at lunch, you're going to start to fill up with fluid even if you're on the best medicines. Non-steroidals we'll talk about, unfortunately, vasoconstrict the heart and the kidney arteries and have been shown to be dangerous when you have heart failure. Alcohol, as we talked about, can become a toxin to the heart, so we talk about alcohol consumption and limiting it, or if really the heart is precariously weakened, stopping in alcohol altogether. We look closely to make sure you're not having blood flow problems. Maybe at first your heart was attacked by a virus, but 10 years later we need to make sure you're not having cholesterol problems. The heart doesn't pump blood as efficiently as normal, so your blood is a little bit more viscous and is prone to clots and strokes, so a lot of our patients are on blood thinners. We talked about arrhythmias and we put defibrillators in. Anemia and heart failure is a bad combination. We really work with the hematologist and the internist to help prevent anemia, and if you get anemic, figure out why and get it corrected. Immunizations are important. We're going to talk about avoiding obesity in the heart failure clinic. This just talks about that during the winter months when you have the flu and pneumonia, that just like we talked about with COVID, if your heart is weakened, that stress that might put somebody in bed for 3 or 4 days actually can make a person die from it. So we really recommend immunizations for the pneumococcal vaccine and for your yearly flu along with COVID. Non-steroidals, unfortunately, they're not good in people with congestive heart failure. They're great pen medicines, but this was a study done back in 2002 where they looked at 7,000 patients with heart failure. And people who use non-steroidals, Motrin, Aleve, Indocin on a daily basis, there was a 10-fold risk of dying compared to those who didn't use it. And that's probably because it vasoconstricts blood flow to the heart, which is already not working well, and it's vasoconstricting blood flow to the kidneys, which is a very important organ that talks with the heart. It doesn't mean you can't take 1 or 2 Motrin every 2 months when your back goes out, but the person who's taking it daily, we really work with them and their internist or their rheumatologist on getting them on a non-steroidal medicine. We talk a lot about salt and water restrictions. The weakened heart, like we said, is prone to congestion. There are many deleterious hormones that are activated when you develop heart failure that make you retain water or retain salt. So we talk about a fluid restriction and a salt restriction. Smoking and alcohol in a heart failure. We really, especially somebody who's had a heart attack, we need to give up cigarettes or the heart attacks are going to continue. And somebody who is doing all the right things, taking all the right medicines, but is still drinking 3 to 4 glasses of wine a night, when they get the echo and they're frustrated, the heart's not getting stronger, the answer's there. They're still continuing to hurt the heart with alcohol. So we talk about alcohol cessation or definitely getting it down less than a glass. People have asked about exercise in heart failure, and it's been studied and it's safe. It actually, moderate exercise, 3 to 4 times a week for 30 minutes, is quite helpful, and outpatient cardiac rehab is approved by Medicare for people with heart failure, mostly systolic heart failure. Lastly, we talk about needing to understand why you're taking so many medicines, and that really talking about all these hormones that are activated is quite helpful to understand that there's no magic bullet that blocks all those hormones, that you really unfortunately have to be on about 4 to 7 medicines to treat heart failure. And then lastly, a plug for the Heart Failure Clinic. I'm a big believer in it because I think I've seen how it works, but when they've studied heart failure clinics versus just cardiology clinics or primary care, if you have heart failure, and you can read this because we're running out of time, heart failure clinics really, one, help prolong your life, give you quality to your life, prevent you from being hospitalized, and it's probably because they get you on the right medicines faster, they diagnose the problem faster, but as we talked about, not only getting you on the right medicines, but also getting you on the right dose. And then one of the things that the Boulder Heart Failure Clinic is, we really preach that we're available by phone. We are seeing patients in clinic, but we will be there to answer, and we can a lot of times bud a problem before it gets so bad that you have to come in the hospital. So in summary, heart failure is when the heart's not strong enough to pump blood to keep the metabolic needs of the body going. It's very common and it's very expensive. 1 in 5 people in America will unfortunately develop heart failure. Its symptoms are many and unfortunately vague, and they overlap with other problems, but probably shortness of breath, swelling in the body, and fatigue are the most common. An echocardiogram, an echo, is probably the most important test to evaluate and confirm heart failure. It's not the irreversible death sentence it was 30 or 40 years ago. With medicines and pacemakers, actually the heart can get stronger. And this, you can live with a chronic heart problem that you can still hike and ski and enjoy all that Colorado has to offer. Early detection is really paramount. It portends to the best chance to reverse the problem and have the least chance of dying. If one has heart failure, unfortunately, there's many lifestyle modifications to do. And lastly, if you have a heart failure clinic in your community like we do, challenge your doctor to at least have you go for a one-time consultation, but also maybe work with them in coming to see us. Thank you for your time and appreciate it.
Thank you, Dr. Blois. We appreciate your time and expertise. We do have some questions that have come in, and let me call that up. So we had a guest ask, what tests can be done to rule out heart disease if the only symptom is late night shortness of breath that lasts only about 15 or 20 minutes? So you were talking about shortness of breath coming up with minimal
well, I think
the
first thing would be to go to your primary care doctor and get an EKG and let them listen to your heart. A lot of times you'll start to hear certain sounds when the heart's not working well. I think the EKG, if it's normal, they might have you get a chest x-ray and a stress test. Those would be sort of the first couple things, an EKG, a stress test, a chest x-ray. If they're still wondering why you're short of breath, then I think an echo would be the next one.
All right. Can you speak a minute about the differences between men and women concerning heart failure?
So, very good question. The question is the difference in heart failure between men and women. Women have heart failure. A lot of times it occurs older in life related to hypertension, and it's the type we call diastolic heart failure. Men, a lot of times the leading cause is coronary artery disease and heart attacks. The symptoms are often very similar, the fatigue, the shortness of breath, but in women, it seems to be more of an older age problem and more related to hypertension, whereas men, it's more related to cholesterol problems and can occur earlier.
Wonderful. How is the drug inclisiran used to treat heart failure? Inclisiran. Am I saying that right? I don't think I am. Inclisiran.
Not sure what that is.
It is INCLISIRAN.
I'm not sure, so I'm going to have to pass on that one.
Okay, all right, okay. How about the baby aspirin daily? What are your thoughts on that?
So baby aspirin, and aspirin is changing a little bit. We know that aspirin is definitely needed if you've had a heart attack and have a stent or a bypass, or you've had a stroke. Unfortunately, if you don't have that, if you have sort of a virus-induced heart weakening, the recommendations are not necessarily taking aspirin. So aspirin is for people who have had a heart attack with a stent, bypass surgery, or a stroke.
What minimal outdoor temperature do you feel is safe for walking outdoors with CHF?
That's a good question. And what's the lowest temperature you can go outside if you have heart failure? I don't think I can quote you a study on that. What the general thought on exercise and stress to your heart is your heart can handle moderate stress. And so if you're dressed warmly and it's 25 degrees outside and that's moderate stress to your system, I think that's safe to do. What we don't want you to do is really redline it or really stress your heart. Your heart has been injured. It needs to recover. So if going outside in the cold feels like more than sort of mild to moderate stress, I would avoid that if you have heart failure.
If you're on blood thinners, do you have to be on them forever?
The question about blood thinners and how long, it's a very case-by-case scenario, so it's hard to give a blanket statement, and you'd have to sort of talk with your doctor about that.
How would one determine if they're a good candidate for the newer alternative therapeutic treatment you mentioned, replacing other drugs?
I'm not sure
How would one determine if they're a good candidate for the newer alternative therapeutic treatment you mentioned, replacing other drugs?
Well, the one that I talked about is this new one called Entresto. And Entresto is sort of sometimes used in place of things like ACE inhibitors and angiotensin receptor blockers. It's approved for people whose heart is pumping less than 40%. And if you have heart failure and you've had an echo or a heart cath that's showing that it's pumping less than 40%, I think you might ask your doctor about, should I be on, and it's called an ARNI agent, which, but it's, and the one out there right now we have is called sacubitril, but it's also called the trade name Entresto. But you'd have to have just a conversation with your doctor. If your doctor doesn't feel they're qualified to make that decision, then being referred to a heart failure specialist who has a lot of exposure to those could help.
Are treatments for systolic heart failure harmful to patients with diastolic heart failure? No.
So as we talked about, the main classes of drugs that are used for systolic heart failure are beta blockers, ACE inhibitors, angiotensin receptor blockers, and all of those have been studied in diastolic heart failure. They haven't been shown to hurt diastolic heart failure patients, but they haven't had the great survival benefit that systolic has. There are certain drugs that we don't recommend with diastolic or with systolic heart failure, but as far as the other way, most of the drugs that you can use with systolic heart failure, we do use with diastolic heart failure, just not with as much proven study success.
Does BCH heart failure clinic treat all types of heart failure?
So that's a good question, and the answer is definitely yes. We treat people with systolic heart failure, we treat people with diastolic heart failure, we treat people who with, on that chart that showed the 30 different types of heart failure. One of the things being a heart failure clinic is you get referred a lot of different studies and cases, and so we've seen people whose heart has been injured by chemotherapy, has been injured by viruses, has been injured by autoimmune problems. So we are very at ease taking care of all types of heart failure.
Wonderful. That is good to know. Does BCH Heart Failure Clinic allow my family to accompany me during visits at this time?
That's a good question, and one of the things that's been hard with the pandemic over the last year is at times we really have not been allowed to have visitors both in clinic or in the hospital. As the vaccine is coming out and the cases are going down some, at our clinic we allow usually one person to come back as long as they're asymptomatic and not have even fevers and stuff. And we do feel that's really important because there's so much education and understanding that needs to go on with heart failure. And that's what a lot of our, besides getting you on the right medicines and assessing if you need to be on diuretics for fluid dangerously building up, is really answering your questions and communicating what heart failure is. So we do allow visitors, right now only one, and they have to be without signs of infection or anything, but we are allowing a visitor in clinic with the patient.
Statins can affect the brain and muscles. What else is there to lower cholesterol?
The question is about how to lower cholesterol is if you don't want to do a statin. And I'm really, this is a talk on heart failure, so we're going to stay on that. I don't have a lot of time to answer that one.
All right. Can radiation due to breast cancer also put one at great risk for heart failure?
Great question. So radiation to the chest is sometimes needed to treat cancers, but it can have harmful effects on the heart. One, it makes you more at risk of developing cholesterol blockages in your heart arteries. We're not exactly sure the mechanism, but it probably causes an inflammation in the heart arteries, so you're at risk of cholesterol building up. It's not a sure thing it's going to happen, but somebody who's had radiation, especially over the heart, we take very seriously making sure there's no cholesterol blockages. And unfortunately, there can be heart muscle injury from radiation too. So radiation to the chest, especially over the left chest where the heart is, the person needs to think about heart problems.
Is there a benefit to lifeline screenings if you're having slight chest discomfort?
I would say no. Lifelong screenings usually will do an ultrasound of your carotid arteries, an ultrasound of your abdominal aorta, and some type of test to see if you're having any blood flow problems in your legs. But it really is not looking at chest pain etiologies. That would be more an EKG, a stress test, things like that.
We have time for just a couple of more questions. The air quality in Boulder lately has been in the yellow and orange range. Is it safe for someone with heart failure to go outside for a walk?
Yes, I would say yes. Unless it's really in the unhealthy range, exercise is so important. Again, for the heart failure patient, probably in the mild to moderate range, that I think getting out with social distancing and a mask on is good.
And our last question tonight, do you have any heart-healthy diet recommendations?
Well, February is Valentine's and Heart Month. I think we are a community here that has the mountains nearby, the foothills. Exercise is so important. It's not only been shown to help lower cholesterol and lower blood pressure, it's been actually shown to be a great antidepressant. So my health tip, besides obviously eating lower cholesterol diet, is exercise. And that's going to help your heart. It's safe in heart failure, and it's been helpful in so many different medical problems, not only heart related.
Wonderful. Thank you, Dr. Blois. We have come to the end of our time tonight. A recording of this lecture is available at bch.org/livestream. So you can watch this again if you'd like. You'll also receive a post-lecture survey by email. Please take a minute to fill this out. The hospital is very interested in your feedback on our lectures. And again, please visit bch.org for information on COVID-19 vaccinations. Thank you for joining us, and thank you, Doctor, again, and have a nice night.